مساء الخير عليكم جميعا.
دكتور حاتم، ازي حضرتك؟
ازيك يا حاتم، ايه الاخبار؟
اهلا، ازيك؟
ازيك يا حاتم؟
ترى ازي حضرتك؟
الحمد لله. يا رحاب، مش هتبتدي شير سكرين؟
انا هستاذنكم بس انا غالبا بعد ما
هنبدا حالا يا دكتوره لبنى.
دكتور لبنى، انا هستاذن حضرتك بعد التوك بتاعتي، انا هاف تو ليف ربع ساعه كده او ثلث ساعه.
تحب تبدا انت ولا ايه؟
لا هاف تو ليف، بس انا قصدي يعني انا بعد التوك بتاعتي I have to leave.
تمام. طيب, anyway, I would like to start by welcoming everybody to our 8th webinar. Today we have strabismus galore. We're going to take a walk down strabismus lane. Very interesting cases from our eminent presenters. We will start off with Dr. Rahab Asim about a strabismus case following sinus surgery. Dr. Rahab, can you please share your screen?
Kida, can you see my screen? Can you see my screen?
Yes, we can see it.
Can see it. Okay. بسم الله الرحمن الرحيم. Okay. Iatrogenic ophthalmoplegia after functional endoscopic sinus surgery. This case was seen and or operated upon after the FES by Dr. Randa Al-Mufti, Dr. Ghada Gauda, Dr. Rani Abdessalem, myself from the ophthalmic department of Cairo University, and by Dr. Farouk Hassan from the radiology department of Cairo University. What's functional endoscopic sinus surgery? FES is surgical treatment of sinusitis and nasal polyps using nasal endoscopes, like in this picture. The use of these powered cutting instruments, although an advance in sinus surgery, still may result in rapid, irreversible, and devastating complications. The intimate relationship between the paranasal sinuses and the orbit places the orbital contents at risk of injury during sinus surgery, especially surgery of the ethmoid sinuses. As we see in this picture, the ethmoid sinuses are in very close proximity to the orbit, with only the lamina papyraceae in between. So surgery on the ethmoid sinuses can result in damage to the orbit and its contents. The orbit, the extraocular muscles, the optic nerve, and the lacrimal drainage system can be damaged during FES. Here the ethmoid sinus. On surgery on the ethmoid sinus, the lamina papyraceae can be injured with damage to the optic nerve, the extraocular muscles, the lacrimal drainage system, or any part of the orbit. The case I'm presenting here is a case of devastating orbital injury during FES. She's a 23-year-old female who had nasal polyps and pansinusitis. She had 2 previous failed functional endoscopic sinus surgeries. And during the 3rd FES of the right ethmoid sinus, she had injury of the left lamina papyraceae, and the surgeon suddenly noticed a left dilated pupil on table. The patient was referred to the emergency of the ophthalmic department, and she had left completosis, left ecchymosis, subconjunctival hemorrhage, exotropia, hypotropia with limited adduction and limited elevation. Her vision was in the left eye, no perception of light. She had a left mid-dilated pupil with afferent pupillary defect, but intact efferent. reflex. She had intact corneal sensation, which is suggestive of intact nasociliary nerve. And she had a central retinal artery occlusion with a pale elevated disc, pale retina, and a cherry red spot. So no PL, afferent pupillary defect, and central retinal artery occlusion of the left side. 8 weeks later, the ecchymosis and the subconjunctival hemorrhage resolved, but still she had the ptosis, the XT, the hypotropia, and the limited adduction and elevation. There was intact extorsion on attempted elevation in adduction, suggestive of an intact inferior oblique muscle, and intact intorsion on attempted depression in adduction, suggestive of an intact superior oblique muscle. So the case here was palsy of the superior division of the third cranial nerve, presenting with ptosis due to palsy of the left levator palpebris superioris and limited elevation due to superior rectus palsy. The inferior division of the oculomotor nerve was intact, as manifested by intact depression, suggestive of intact inferior rectus muscle, intact extorsion on elevation in adduction, suggestive of intact inferior oblique muscle, and intact efferent pupillary reflex, suggestive of intact parasympathetic fibers which pass in the nerve to the inferior oblique, which is a division of the inferior division of oculomotor nerve. But there was still limited adduction, which suggests medial rectus paralysis, and the medial rectus is supplied by the inferior division of oculomotor nerve. As seen in this picture, the superior division of the oculomotor nerve supplies the levator palpebris superioris and the superior rectus, and both were affected here, while the inferior division supplies the medial rectus, inferior oblique. The inferior oblique and inferior rectus were intact, and also supplies the short root of the ciliary ganglion with the parasympathetic supply to the pupil, which was also intact. On fundus examination 8 weeks later, she had attenuated retinal arteries, subretinal pigmentation, and an epiretinal membrane over the posterior pole. Scan and MRI of the orbits, brain, and sinuses was performed, and it revealed a defect in the nasal septum, destruction of the interethmoidal septi. There was also a defect in the medial orbital wall, in the lamina papyracea, with herniation of the intraorbital fat into the ethmoidal air cells, and there was loss of continuity of the medial rectus and the optic nerve, whether cut or obscured, and the medial rectus and the optic nerve were entrapped in the medial orbital wall or in the lamina papyracea defect. So we have here a third nerve superior division injury, medial rectus injury and entrapment, optic nerve injury and entrapment, and central retinal artery occlusion, all on the left side. 7 months after FEST, there was still no improvement of ocular alignment or ocular motility, so orbital surgery was performed. Orbital surgery revealed a positive force-duction test of the left medial rectus and lateral rectus. A transcanalicular medial orbitotomy was performed to expose the medial orbital wall fracture. The left medial rectus and the optic nerve were found entrapped. The medial rectus was freed, and a mid-pore implant was inserted to close the medial orbital wall defect. However, 3 months later, there was still no improvement of alignment or ocular motility, so strabismus surgery was performed. The force-duction test of the left medial rectus was still positive, probably due to the presence of extensive adhesions, but the medial rectus was intact. Left lateral rectus recession and medial rectus resection were performed. 6 weeks later, there was partial improvement of alignment and ocular motility. This is her picture 6 weeks after strabismus surgery and 1 year after the FEST. She had left partial ptosis, left exotropia and hypotropia, and left limited elevation of adduction and elevation. So on analyzing this, exactly during the FEST remains obscure. There are possible scenarios. One of them is widening of the pre-existing minute nasal septal defect by surgical instruments. This defect happened during the first two FES surgeries. The instrument then crossed from the right to the left side through the septal defect to injure the left lamina papyracea, where rarefaction of the ethmoid sinus facilitated entry into the left orbit. Medial rectus entrapment followed by optic nerve entrapment into the lamina papyracea defect ensued. So as seen here, before the third FES, she had a minute nasal septal defect, and after the third FES, then the septal defect was much larger. So the instrument passed from the right side through the septal defect, through the ethmoid bone, which was rarefied, through the lamina papyracea into the orbit, and then the medial rectus and the optic nerve got entrapped in the lamina papyracea defect. Trauma to the optic nerve caused spasm of the central retinal artery and subsequent occlusion, or direct injury of the central retinal artery might have happened and caused the occlusion. Lastly, the instrument injured the superior division of the oculomotor nerve that crosses superiorly on the lateral aspect of the optic nerve to supply the superior rectus and the levator palpebris superioris muscles. Here's the superior division of the oculomotor nerve crossing over the optic nerve. Alternatively, the limited ocular motility might be due to extraocular muscles contusion rather than nerve injury. Not resolved, so it will probably not contusion. Or motility might be due to injury to the ophthalmic artery with the resultant extraocular muscle ischemia. The ophthalmic artery passes here in the orbit close to the optic nerve. It might have been injured and produced what's called the orbital infarction syndrome, with ophthalmic artery hypoperfusion resulting in extraocular muscle ischemia causing ophthalmoplegia and central retinal artery hypoperfusion causing blindness. However, not all extraocular, it's not orbital infarction syndrome, but probably it's direct injury of the superior division of the third nerve. So this is a case of third nerve superior division injury, left medial rectus entrapment, and optic nerve entrapment, and central retinal artery occlusion, whether due to spasm or injury following FES. Thank you.
Thank you. A very interesting case in a rather traumatic, unfortunate surgery. I would like to ask Dr. Lubna, Dr. Hala, Dr. Hatem, Dr. Ahmed, Dr. Ghada, if anybody would like to have any questions.
Can I say something? Because I had a very similar case like this that I did with Dr. Tamer Gaudat, and I had the exact same findings. I think that much what I performed, I did a recess resect. I didn't have the hypotropia though. So I was thinking that, did you consider moving the medial and the lateral rectus muscles up to help correct the hypotropia that you had? I still had was that another circle option here, since actually I was a non-seeing eye. So a splitting of the lateral rectus, moving it towards the medial rectus the other side, might have about the complications of doing this type of surgery. So and I would like to know if anybody else has anything. Thank you.
Dr. Hala, thank you so much. Definitely, these are so valid options. But actually, during surgery, intraoperatively, there was a lot of fibrosis. It was so difficult, and it was very difficult. The safest thing that I could do was surgery, but she refused, and she was so much satisfied, and she afterwards. That's why I think I just chose the safest way, which is research. Around 4 months post the endoscopic sinus surgery. She couldn't interfere before that. There was a lot of edema, and she chose to postpone the surgery until 4 months lapsed. What was the final result after the orbital surgery? And despite that, the orbital surgery was very successful. She did CT or something like that afterwards, and there was no entrapment of muscle, but still yet there was a lot of adhesions, and moving the globe was really difficult. There was positive force reduction test, and it was a difficult surgery. That's why I just tried to shorten the time of the surgery as much as possible.
Hey, Rehab, thank you very much for the nice presentation and the analysis. It's a very difficult case due to fibrosis, actually, as Ghada Gaudat said. The timing of interference, Ghada, after 7 months, the accident is okay. It's not late. You are waiting for recovery of any muscle, especially the medial rectus is intact. It is not injured or cut. So the timing is proper. The option of doing transposition of the lateral rectus is a very good option, but in the presence of severe fibrosis, I think it is not going to be easy and effective. How much did you do medial rectus resection or plication?
I did 6.5 millimeter resection.
Why not more than that?
I couldn't do more than that.
You couldn't.
I couldn't.
I think if you could do more than that, it is going to be much better to improve the alignment. And the maximum recession of the lateral rectus, the option of transposition. Hypertropia, it should have been done. It's a very option to improve the situation, and I think it wasn't difficult, or it wasn't going to be difficult in this situation. Instead of recessing for example, the inferior rectus or something like that, it's a very good option, as Dr. Hala said. But it's really a very difficult situation, and it's a disaster.
Next time, inshallah.
أنا بس كنت عايزة add in my case, actually, surprisingly, there were not that much adhesions around the medial rectus. I think it was mainly, in this case, a nerve injury, and the muscle was actually
the presentation, he will be talking about a very weird tropia. Dr. Had, can share your screen, please?
ظهرت دلوقتي ولا لا؟
ظاهرة حضرتك.
دقيقة واحدة. مشكلة أنا عندي معلقة.
ممكن نبدأ من اللي هو الزرار بتاع السلايد شو. start slide show.
لا أنا عندي الزوم كله معلق.
احنا شايفين الشاشة.
انتوا شايفين الشاشة كده؟
احنا شايفين هو حضرتك لما بتعمل يمكن صورة حضرتك بس احنا شايفين الشاشة. لو حضرتك تدوس بس على سلايد شو هيبقى.
ممكن حضرتك تدوس على F5 يا دكتور حاتم. F5 لو ما اشتغلش يبقى حضرتك معلق عندك البروجرام.
أنا كده معلق عندي يعني.
حضرتك تقدر تقفله وتفتحه تاني الباوربوينت.
الباوربوينت طب can you move to the next speaker لغايه ما اظبطها بس؟
حضرتك ممكن طب شيرنج على الاقل.
Dina, are you ready?
طب كده
لو دكتور حاتم
هتحاول تاني دكتور حاتم الاول؟
حاول تاني دقيقه واحده. لا بليز انتوا بتهيألي موف اون تو النكست سبيكر لغايه ما اظبطها بس.
تمام. باقي دينا لو امكن.
اوكي
تمام. Dina is going to be talking about congenital cranial degeneration disorders and whether it is or not.
Thank you, Rasha. Good evening, everyone. My case today is an 18-year-old female patient. She came complaining of having a weird-looking eyes, as mentioned by her parents and her friends. Her general examination revealed an abnormal head posture of a mild chin-up position. She had no significant history of trauma or previous eye surgeries and a negative family history of similar conditions with a positive consanguinity of the parents. Her anterior segment examination was normal. Her best corrected visual acuity was 0.7 in the right eye and 1 in the left eye, and she was a myopic astigmatic patient with a fundus examination that was a tigroid fundus. The extraocular motility of this patient revealed a limitation in the up gaze, where in all the directions, in the straight up gaze, and in and up and in, and the out and the up and out positions. Also, in the down gaze, there was a limitation of a -3 in the straight down gaze and in the down and in and the down and out positions. She also showed a limitation in the horizontal gaze in the form of a limitation of a -1 in the medial in the adduction and a limitation of a -3 in the abduction in both eyes. By examination, she also showed a right esotropia of 18 to 20 prisms for near with correction, and that angle increased for distance to 40 prism diopters with a no specific pattern. Trying to reach the diagnosis of my case, her family history was negative. I asked about if this condition was recent or an old condition. Also, I asked if this was progressive or stationary. I asked her to show me a previous photos dating since childhood. And as investigations, I asked for neuroimaging for MRI brain, for a thyroid profile. I also asked for a full neurological assessment. The next visit, the patient came to me with a normal MRI brain and orbit, with a normal thyroid profile, and her neurological assessment was insignificant. She brought to me also a childhood photo, which showed that this condition seemed to be a condition dating since childhood, as the esotropia was present also in the photos that they brought to me. So to summarize my case, this is a case of a bilateral, almost symmetrical external ophthalmoplegia. The limitation in motility is more in the up gaze than in the down gaze. The limitation in the horizontal gaze in abduction is more than in adduction. And she has mild ptosis, mild chin up position, and the condition seemed to be dating since childhood from the photos that the child got to me, that the patient got to me. And whether this condition is non-progressive or progressive, I couldn't actually say, but I assumed that it was a non-progressive condition from the photo of the childhood photo that I saw. So I thought of a diagnosis of having a congenital fibrosis of the extraocular muscles, which is considered as one of the congenital cranial dysinnervational disorders. These disorders are a group of neurodevelopmental diseases of the brainstem and the cranial nerves. Endogenous or exogenous disturbances lead to primary disinnervation of the structures supplied by the cranial nerves, resulting in motility disturbances and potentially structural changes later on occur. So I made something like a checklist to see what was suiting my diagnosis, whether this is a congenital fibrosis of the extraocular muscles or not. And I found that it was a congenital non-progressive disorder with showing restrictive ophthalmoplegia with a defect in the vertical eye movement, especially in the up gaze. The horizontal eye movements that were present were defective also, and the eye alignment shows esotropia in the primary position. However, what was not matching was the diagnosis that I couldn't find the severe congenital ptosis, and the eyes were not stuck in the introduction of what we were used to see in these patients, and there was no prominent chin up position. Congenital fibrosis of the extraocular muscle have three types: congenital fibrosis type 1, type 2, and type 3. They are classified according to the phenotypic presentation with an overlap between these types, and the genetic classification can be more informative. The classic type of the congenital fibrosis type 1 is an autosomal dominant disorder in which we usually see a prominent congenital bilateral ptosis with inability to elevate both eyes above the middle line, with restricted horizontal movements and a compensatory chin up position. And it is usually symmetric and not associated with any additional neurological abnormalities. This was very close to my case, except for the absence of the severe ptosis. Type 2 is the autosomal recessive disorder, which presents also by a congenital non-progressive bilateral ophthalmoplegia and ptosis. However, the eyes are primarily exotropic, and this was not my case, and they show also restriction in both horizontal and vertical eye movements. Type 3 had some criteria that was close to my case in that it has a variable phenotype. So this type can range actually from having a relatively mild disease to a severe disease. The patients can even have a unilateral or an asymmetric involvement. The ptosis may not be present at all in this type, but what was against my diagnosis is that the congenital fibrosis type 3 usually shows exotropia in the primary position, and they are commonly associated with other neurological abnormalities. So I had to put other differential diagnosis for my case. Could be a case of an isolated third nerve palsy, which can either be unilateral or bilateral. It can be easily confused with a congenital fibrosis of the extraocular muscles type 1 or type 3. However, the case is usually, these cases are usually exotropic also, which was not my case, and they can be distinguished by the more profound restriction of the up gaze in the congenital fibrosis of the extraocular muscles. Chronic progressive external ophthalmoplegia, which is a mitochondrial disorder that has a later onset and a slowly progressive course, the adults having such condition can appear similar also to the congenital fibrosis of the extraocular muscles. Isolated congenital ptosis can be distinguished easily by the presence of free ocular motility, and congenital myasthenic syndrome, in which the ptosis is fatigable, that's to say that the ptosis is variable, and muscle weakness is of multiple muscle groups and is not limited to the extraocular muscles. I had to put also the other CCDDs in my differential diagnosis: Duane syndrome, horizontal gaze palsy, also some cases of congenital fibrosis of the extraocular muscles type 3 show associated facial nerve palsy or weakness and are initially misdiagnosed as Mebius syndrome. However, the classic Mebius syndrome show esotropia, and congenital fibrosis type of the extraocular muscles type 3 shows typically exotropia. I actually, when I revised the photos of the patient, I also noticed that the patient showed some sort of facial weakness, especially on the right side of her face. So the decision was that I took was to operate for this young lady. Whether to do a unilateral or a bilateral media rectus recession, I was skeptical of doing bilateral, although the angle for distance was 40 prism diopters. So I decided to work on the angle for near, and I decided to work for a unilateral media rectus recession 5.5 millimeter after discussing the possibility of the need for another surgery with the patient. Intraoperatively, the force reduction test revealed a positive force reduction test for all the recti. The medial rectus muscle was not, however, as tight as what I was used in cases for congenital fibrosis of the extraocular muscles. Post-operative, the patient was satisfied. She had an improved look, an increased field of vision as subjectively described by the patient. And the post-operative examination revealed an she had orthotropia for the primary position and the residual esotropia of 10 prisms for distance. However, the patient disappeared and then returned again 7 months later, having a residual right esotropia of 12 to 14 prisms for near that increased also to 30 prism diopters for distance. I decided to work on the left media rectus and to do a left media rectus recession of 5.5 millimeters. The post-operative results showed an orthophoria for near and exophoria for distance. This was how the patient looked pre and post, but still I had a lot of questions in my mind. Was I correct in my diagnosis? And the cases of congenital fibrosis of the extraocular muscles having mild ptosis, not showing what we are accustomed to see, like the severe congenital ptosis they present with. Also, would you proceed with the surgery in adults presenting with ophthalmoplegia who don't report any history, whether the case is a stationary or progressive? And for how long can I stay monitoring this patient before I decide for surgery? Were there any further investigations that were missing and I should have asked for this patient? And which angle that I should work on, the distance or the near angle in such cases? By the end, I still have so many questions that I don't know what is the proper answer for them. And this was my case, and thank you for your attention.
Thank you, Dina, very much. I'm sure also the audience and I'm sure our panelists will have questions. We can start with Dr. Lubna.
Dina, the presence of limited abduction is not with partial third cranial nerve palsy. And in the pictures, the ptosis is not marked. And in congenital fibrosis, it's very characteristic when the patient looks up or tries to look up, there is marked esotropia, which is not present in your case. Did you examine the hypoglossal nerve? Is there any abnormality of her tongue?
Yes, yes, there was no abnormality. No. No abnormality.
The presence of the facial nerve, the sixth nerve, the marked limitation, and the facial as well. It may be a form of
Moebius syndrome.
Moebius, yes.
Yes, I thought of that also, but the limitation in the up gaze was so marked. Yani she had a limitation in the straight up and the up and out and in the up and in positions, almost -4, no limitation. And still, I don't know whether my diagnosis was correct or not, because as you said, Dr. Lubna, because she had a very mild doses, and this was really the first time for me to see a case of, if I consider this a case of congenital fibrosis, having that.
But in the literatures, the presence of marked ptosis is not a must. There is variants of the congenital fibrosis in which there is mild or even no ptosis. The conclusive diagnosis is by genetic analysis, which is not, I think, available, and it's very expensive. As you said, there are 3 types of genes: the FOX, the TAP, and the KEF. KEF for type 1, FOX for type 2, and the TAP for type 3. Yes. It should have been done, and I know it's not very expensive. It's difficult and very expensive here in Egypt. What you did is okay as regards the medial rectus recession, which should be, I think, it should be bilateral from the start, not unilateral. I don't believe of unilateral surgery in such situations is going to correct the situation. Being she doesn't have any binocular vision, so we are not afraid of any diplopia post-operative.
Yes, she does, but I was really scared that I get overcorrection for these patients, because she had very tight medial rectus intraoperative, and there was a positive force reduction test for all the horizontal, for all the recti muscles. I was really scared of getting an overcorrection, and I discussed this with the patient.
You didn't try adjustable sutures in such situation?
No.
She's an adult and she can tolerate adjustable suture, I think.
Yes, I know.
To get a reasonable angle as regards the near and far.
Oh.
This is an option.
Can I ask a question?
Yes.
Dr. Lubna, how do you explain that she is her angle is more for far than for near? Is it because of the when she tries to look for far and she has more limitation of abduction? So
this is why I thought of Moebius syndrome of lateral rectus paralysis, because the limitation of abduction is much more than the limitation of adduction.
يعني تفضلي دكتورة هانم.
Yes, Rasha, yes, continue.
I was asking, these syndromes are families, and they can be autosomal dominant in the family.
الصوت بيقطع يا رشا، أنا مش سامعاكي كويس.
دينا تفضلي.
And I cannot hear you properly.
Sorry, I was asking if there are siblings or any family member that has any similar condition.
No, just
negative.
Yes, just positive consanguinity of the parents and no other similar conditions in the family. They can occur also in sporadic cases, but this is the rarer condition.
And type 2 is recessive.
Yes, type 2, but yes, type 2 is recessive, yes.
But mostly exotropic, not esotropic.
That's why I didn't go with its type 2. It could be either Möbius syndrome, but with a limitation in the up gaze, which is against the revised criteria for the diagnosis of Möbius syndrome, that they shouldn't be having any limitation in the up gaze, but or a congenital fibrosis type 3. But what was against was the presence
No
of
neurological.
yes, and the presence of exotropia, and all the cases described were exotropic, not esotropic. But this is the only. I think they have a lot of phenotypic presentations. Congenital fibrosis just have a lot of phenotypic presentations that may overlap together. So
Yes.
it might be some sort of an overlap between these types.
Yes. Most probably. And the facial palsy is present early also in childhood? Since
No,
birth?
the photo that I saw didn't show any deviation, but the patient was really strange because she used to wear glasses since childhood, and she was never told that she had anything abnormal with her motility or with her muscle balance. And this was strange for me, and she's 18 years old.
Are you sure it is not something progressive?
That's why also I put a congenital, I put also chronic progressive external ophthalmoplegia as a differential diagnosis. Hopefully she's not, that's what I saw from
the fundus picture. Is there any pigmentary changes or something?
No fundus
not at all.
changes. Yes, no, and no cardiac problems. Yes.
Bundle branch block or something like that.
No, hopefully she's not.
Yeah, you investigated her.
I asked, yes, I asked particularly about this point.
Because I had, when I was assistant lecturer, a picture similar to that, but it was progressive. She was an 18-year-old girl, and she had pigmentary changes in the fundus, and I sent her for cardiological evaluation, and proved to be to have a bundle branch block, and she died after that. But it was progressive from the history.
Hopefully she's not.
There is no multiple pictures, just the one with the esotropia.
Yes.
You don't have any pictures at advanced age or something like that.
No, this was only.
No, this is the only one.
They brought for me. The family brought to me.
Yes, I think it's an overlap of abnormalities. Maybe.
Yes.
But the aim is to reach a reasonable cosmetic appearance. This is your aim. Not to improve the motility because of the very tight muscle, and she doesn't have any marked chin up position.
Yes.
So dealing with the hypotropia or the limitation of elevation, I think it doesn't bother her.
Yes. Yes. Thank you, Dr. Lobny.
Anybody else would like to ask a question? اوكي دكتور حاتم، اخبار حضرتك ايه؟
باينه قدامكم ولا البرزنتيشن؟
احنا باين الكمبيوتر بس مش باين حضرتك، لسه ما فتحتش البرزنتيشن.
لا يبقى عندي بروبلم جسيمه مش عارف احلها.
حضرتك عامل شير مش للبرزنتيشن، عامل شير للديسكتوب.
عامل شير للديسكتوب.
بعد اعمل ستوب شيرنج، وبعدين لما تعمل شيرنج تاني اعمل شير للباوربوينت. ستوب شيرنج الاول، وبعدين لما تعمل شير حضرتك نقي البرزنتيشن مفتوحه.
البرزنتيشن مفتوحه
حضرتك اما تنقي بقى شير، حضرتك شير برزنتيشن، شير باوربوينت، مش شير ديسكتوب.
هل ظهر كده؟
كده. F5 سلايد شو F5.
F5
ايوه.
هل ظهر كده؟
هي ظاهره يا حاتم بس مش سلايد شو.
حضرتك دوس
مش
على
عارف
زرار
النهارده.
على الايكون اللي تحت يا دكتور حاتم، اللي هو الايكون اللي تحت على اليمين بتاع السلايد
ايه
شو.
الايكون تحت؟
ايوه ايوه ده هو ده،
أيوة ده.
دوس عليه.
كده ظهرت؟
تمام.
تمام.
كده تمام.
Okay. Okay. First of all, I would like to welcome all the audience to this very special episode of Strabismus Interesting Cases. The case I'm going to show you to now may be much simpler than you think, yet it's a little bit weird. This is a case of consecutive alternating intermittent exotropia following a surgery for esotropia performed elsewhere a couple of years ago. A straightforward bilateral lateral rectal secession through a fornix approach
الصوت
was
بيقطع يا حاج.
performed and it was completely and this is the result. The eyes are perfectly aligned. سامعني كده؟
yes.
Okay. I thought that the story of this young girl has ended by that time, and the child was scheduled for a follow-up visit 1 month later. At the follow-up visit, the mother insisted that the left eye drifts up occasionally, and this started maybe 2 days ago. At first, I didn't notice any deviation, but after a while, an intermittent left
دكتور حاتم ممكن حضرتك
hypertropia
تقرب صوتك
started to
المايك؟
appear sometimes. Okay. كده سامعني كويس طيب؟
كده سامعين
سامعني كده؟
حضرتك.
Okay. So I ran in my mind through the possibility hypertrophy following bilateral DVD and the PD and congenital dystrophy. Second possibility is the inferior oblique injury, although it's very uncommon after lateral rectal secession, but an inferior oblique injury in the right eye can cause a left hypertropia while fixating with the right eye, but this hypertropia should be immediate and should be constant. So this is against this diagnosis. The third one is inadvertent vertical shift of the lateral rectal
حاتم الصوت مش مسموع يا حاتم.
حاتم الصوت بعيد جدا، لو حضرتك تقرب شوية. دكتور حاتم.
وبالتالي المشكله في الانترنت
smaller angle than مع ان انا مش طالع لي هنا الانترنت الكونكشن ضعيفه يعني. كده احسن؟ هل سامعني كده ولا لا؟
كده احسن، كده
كده
احسن،
سامعين حضرتك.
بس ساعات بيقطع خالص ما بنسمعكش.
غريبه جدا. هو النهارده الزوم فيه حاجه غلط عندي.
في عكوسات.
في حاجه مش مظبوطه. The abnormal polytheory doesn't fit in this case لانها it should be immediate and should be constant. The fifth possibility came to my mind is an overlooked left inferior oblique overaction, primary or secondary, and this should be immediate and constant as well. So by examining that child, it is not a DVD. It's a frankly intermittent left comitant hypertropia, not a dissociated one, which means that when she fixes with the left eye during the hypertropic phase, the right eye goes down. There wasn't any significant fund distortion. The vertical three-step test was inconclusive. And to evaluate the oblique muscle dysfunction, I had to revise the preoperative photo that I always take. As you can see here, there isn't any significant preoperative oblique dysfunction. The only thing here seen is this mild adduction deficit of the left eye. This can be caused by an over-recessed medial rectus in the first surgery. So all what's found points at the left, intermittent superior rectus hyperactivity of unknown etiology. And this urged me to seek some neurological workup to exclude skew deviation or any other diagnosis of that sort. And a week later, when the parents brought the results of the MRI that were negative, by the way, to me, the mother noticed that the intermittent hypertropia totally disappeared. And I found that not to be very much true. I failed to see any hypertropia in the left eye, even intermittent one. And this stayed till the latest follow-up, which was 4 months post-op. So the reason for this left intermittent hypertropia remains unclear to me. I don't know the diagnosis of that situation. And I find, like, as a final comment to my presentation, I advise you all to photograph all your cases, even the ones that you think that simple and straightforward. This might
دكتور حاتم حضرتك سمعنا لأن صوت حضرتك بعيد.
طب حاتم, may I ask you? حاتم?
اتفضلي ترد.
You heard me. Okay.
ايوه معاك يا ترد.
As long there is some limitation of adduction, why didn't you start with the advancement of the medial rectus muscle?
ما هو بالظبط ده السؤال اللي انا كنت متوقعه. وفي سؤال تاني كان متوقعه.
طيب طب جاوب على ده الأول.
I usually recommend an advice to advance the medial rectus. But in this specific case, I was studying another point that necessitates doing the lateral recti. Why I felt that the angle wasn't that bad, and that was really corrected with the surgery.
Yes, but I mean, so long there is limitation of adduction, it is much better to do advancement. Otherwise, you may be confronted with recurrence of the deviation again. Later on, after a year, after a two, more of consecutive exotropia. So if you strengthen the medial rectus and put it back in place, I think this will avoid the recurrence of the deviation.
I always do this.
I have a similar case, Hatem. I did an app procedure with transposition of the medial rectus and lateral rectus to the superior rectus muscle for a monocular elevation deficit. And I was confronted with limitation of adduction, which was very strange. I do respect the spiral of Thiloux during transposition, not to be confronted with horizontal misalignment after the nap. But I found that there is limitation of adduction, and the photographs pre-operatively, there was no limitation of adduction. As you said, it is very important to photograph patients pre and post. And I reopened, and I thought that the medial rectus, there is any abnormality, it is slipped or something like that, but I found it in place and very good in place. So I thought there is abnormality of the pulley, maybe it's an explanation of an abnormality of the pulley when I transpose the medial rectus up. It causes such a limitation. I don't have a good explanation for that. For sometimes you are faced with strange situations after doing regular surgery and the muscle was in place.
بس هنا اللي غريب الهايبرتروفيا اللي هي intermittent وملهاش اي تفسير.
ملهاش تفسير وبعدين سيلف كوركت.
ومش دي في دي وما هياش دي في دي.
شور مش دي في دي.
لا شور مش دي.
انت you said that it is comitant deviation, yes.
I have no explanation. Anybody view so حاجة like this?
دكتورة هالة, Ahmed, would you like to comment?
No, I actually don't have any specific explanation. The only explanation is the hypertrophy was present before surgery and it was somehow controlled by the patient by some kind of versions, some kind of high version, vertical versions. but the patient after surgery lost it for a while and then regained this Verges mechanism. This is the only explanation I can have.
Can I add this? First of all, I think I agree in think the mid-thigh is always better, going back to the medial recti, to see why the consecutive exotropia took place. And usually we find a stretch scar or something there, especially limitation of adduction. The only thing with your explanation, Ya Ahmed, هي in I think that would have appeared before the surgery with the alternate prism and cover test and breaking down of perfusion. So I'm more leaning towards maybe while they were recessing the lateral recti, maybe on the right side there was like a small either hematoma of the inferior oblique, maybe, or like a tiny adhesion that was there between the two muscles, and then that went away. That's my explanation.
But it was immediately after, for 1 month after the surgery, she was straight. She started to deviate 1 month after the surgery.
I know, but because I don't see anything else that could explain that.
I don't have anything. I don't have any explanation. I thought it was a skew deviation.
Skew deviation, there is any torsion of the fundus? You said there is no torsion.
There is no torsion, yes. I thought something neurological, yeah.
She would have had some other neurological sign.
Like nothing.
For there to be a skew deviation.
يعني هي الdeviation that started مثلا 3 weeks after the surgery, lasted for 10 days and then disappeared.
Maybe a form of decompensation of already يعني present hyper, and it is decompensated, maybe. I don't know.
Or maybe the mother just didn't notice it except after 1 month, but it was present immediately post-operative. Maybe because
I saw it post-operative. I saw it.
Maybe you saw her while she's controlling the deviation, maybe. You didn't examine her with the filters or something to elicit any vertical misalignment.
Yeah, بس يعني هي أصلها كانت.
Yes, I know you don't think of that. Yes, it's difficult to expect that. Yes.
Well, thank you, Dr. Hatem. Our next presenter, Dr. Ahmed Awadin. So if we had reached the diagnosis that it is a congenital cranial dyssynervation disorder, what to do next?
As Dr. Alina already mentioned, the main types of congenital fibrosis of the extraocular muscles are type 1 and type 3, which are autosomal dominant, and type 2, which is autosomal recessive. There are other forms which are far less common. In type 1, the eyes are fixed in the hypotropic position and the patient is adopting a chin-up position. You can notice that there are restrictions of the vertical eye movements and associated with the inward movement of the eyes and upgaze, as Dr. Lubna already stated. The condition is almost always associated with ptosis. Type 2, which is far less common, the exotropia is usually their predominant feature. The eyes are vertically midline. This means that there is no significant hypotropia, but there are restrictions of both the vertical and the horizontal movement. And again, ptosis is a very common finding. Type 3 is characterized by being markedly asymmetrical or unilateral. The findings are very variable. Usually the patient is exotropic, but sometimes you can find either or weird findings. Now, exotropic congenital fibrosis is very difficult to manage. In the milder forms, such as in this child, usually we tend to do a bilateral large lateral rectus recession, but still you sometimes end up with late recurrence of the exotropia, and of course the limitation of the eye movement will persist after surgery. My talk today will be about management of some severe forms of congenital fibrosis of the extraocular muscle, management of the exotropic type. So today I'm going to present two cases of an exotropic congenital fibrosis with different lines of management. This is the first patient. She was a 20 years old female with a negative family history of congenital fibrosis. The eyes are fixed in the exotropic position. Notice that there is limitation of the vertical and the horizontal eye movement, and the patient, because of the large exotropia, is adopting an alternating face turn to be able to fix. Because the eyes are exotropic, she has to turn her head to one side in order to see with this eye. Now, in severe cases like this, I tend to counsel the patient to start with that you probably will need more than one surgery. And you always expect a new type of strabismus to develop. For example, after correcting a horizontal strabismus, you sometimes end with getting a vertical strabismus or the other way around. And eventually, at the end, the patient will probably need to do a ptosis surgery, but after ending all types of eye muscle surgeries. So in this patient, because of the very large angle, I opted to do a bilateral lateral rectus orbital wall fixation. This is done through a limbal approach. The lateral rectus is hooked. You can see it is very tight, adherent to the globe. The muscle is secured with 5-0 polyester non-absorbable sutures. And then the lateral rectus is disinserted from the globe. Then using two instruments, the soft tissues overlying the lateral orbital wall are pulled to each side in order to expose this white tissue, which is the orbital periosteum. And then the needles are passed in the lateral orbital wall in the periosteal tissue, and the muscle is pulled all the way to secure the lateral rectus to the orbital wall. So the question, will this be enough? Still, because the angle was very large, I thought that this won't be enough to correct the very large angle of exotropia. So I combined it with the right medial rectus resection of 8 mm, and I thought of leaving the fourth muscle, which is the left medial rectus, for a possible future surgery, because if you ended up with undercorrection, you need to have something to work with. Post-operatively, you can see there is only a slight improvement of the exotropia, but still you have a marked residual exotropia. So of course, I told the patient you will probably end in needing a second surgery. You can see this is the appearance of the patient after the lateral rectus orbital wall fixation and the right medial rectus resection. This is a comparison of her photo before surgery and after surgery. You can see there is only a little improvement. So I decided to go back and do a left medial rectus resection. Remember that the left medial rectus was not operated upon, and to do a re-resection of the right medial rectus for another 4 mm. And post-operatively, the patient was slightly better, but still we have a large residual exotropia. You can see this is the appearance of the patient after the first surgery and after the second surgery, only with a trivial improvement. And the question I always ask myself, is this the best alignment I can get in these cases? So I got this second patient, quite similar to the first patient, but this time he is a male, a 45 years old male, working as a video photographer. He has two brothers with congenital fibrosis of the extraocular muscles. The eyes are fixed in the exotropic position, again with the limitation of the vertical and horizontal movement, and adopting an alternating face turn to be able to fix. You can see it's like a mirror image of the previous patient. And I did for him exactly the same technique I used for the first patient. I did a bilateral lateral rectus orbital wall fixation, and again combining it with the right medial rectus resection, leaving the left medial rectus for future surgery. And as you expect, I got almost the same result as I got with the first patient, only a small improvement of the exotropia, but still a marked residual exotropia. And again, the patient is adopting an alternating face turn in order to be able to fix. So the next question, what to do next? I already know from the previous surgery that I will have to go back to do a left medial rectus resection, and a resection of the right medial rectus. But the question I always ask myself, can I do something different in order to improve the alignment? So I started the second surgery by doing a force reduction test, and I found that the lateral recti are negative now because they are fixed to the orbital wall, so there is no residual tightness in both lateral rectus muscles. This ensures that the muscles are not attached to the sclera again. And then I proceeded to do by medial rectus resection. But what I added differently in this patient is that I explored both the superior oblique muscles, and I found that they were very tight. So I did something different. I did a bilateral superior oblique nasal tenotomy, and I also made use of these tight superior oblique muscles by medial transposition, like what Scott recommended. This is the appearance of the patient second day after surgery. You can see that this time I got a marked improvement in the alignment. The eyes are almost orthotropic in the primary position. So this is the appearance of the patient after the first surgery, and this is the appearance after doing a bilateral superior oblique nasal transposition. Now, there are some reports, recent reports, about the role of the superior oblique muscles in the pathogenesis of congenital fibrosis of the extraocular muscle. Dr. Hunter in 2019 reported that about half of the patients who underwent superior oblique surgery for congenital fibrosis of the extraocular muscle have abnormalities in the superior oblique tendon, and about 50% have tight muscles and abnormalities in tendons that was not previously described. However, this has been reported mainly in the pathogenesis of the hypotropia in congenital fibrosis of the extraocular muscle. But I believe that the superior oblique also has a role in inducing the exotropia in exotropic congenital fibrosis of the extraocular muscles. But the problem now that I got with this patient is a new complaint that I never got before, that the patient now is complaining of double vision. Because as you can see, this patient had almost eyes that looked 180 degrees from each other. Now I think it is for the first time in his life that eyes are looking straight ahead. And he has some bothersome diplopia. I'm not sure whether it will go away or not, but this is the main complaint of the patient now. Thank you.
Thank you. Thank you, Ahmed. Very difficult cases indeed.
Yes.
I just have one question. Would you have considered also working on the inferior oblique, yani like transposing it as well as yani, I don't know, would that have helped as well?
I'm not sure whether I can transpose it or not, but there is always a chance of just cutting it because you already cut the superior oblique, so you can cut the inferior oblique. It might play a role in inducing some exotropia, but I'm not sure. But it has been described before in the management of exotropic congenital fibrosis.
Ahmed, طبعا it's a very, very nice case and very nice management. Hatem Saeed, you remember we had a paper published maybe 20 years ago of such bilateral exotropia, and we had cases of bilateral congenital third nerve palsy and congenital fibrosis in the exotropic and wall-eyed syndrome. And we presented, you remembered Hatem, huh?
ايوه ده من سنه 99.
كنا صغيرين. This is the differential diagnosis of the cases, whether wall-eyed syndrome or congenital fibrosis or strabismus fixus in the abducted position or the bilateral congenital third nerve, which is very rare here. And I do think the exotropia is probably due to superior oblique tightness, even in the esotropic congenital fibrosis syndrome. Sometimes in the esotropic type 1 congenital fibrosis for extraocular muscles, after you recess the inferior recti, you are confronted with exotropia. So surgery, I found that the superior oblique was abnormal, and tenectomy of the superior oblique improves much of the exotropia, even in esotropic fibrosis syndrome. This is very important. And if not, if the inferior of the superior oblique is not found tight, why not, Ahmed, to think of fixation of the medial rectus to the medial orbital wall?
Ahmed, مش سامع.
Okay. I mean, fixation of the medial rectus or fixation of the sclera to the periosteal flap?
As done in third nerve palsy, as done. I didn't do that, but I'm just thinking, if you found the superior oblique normal, not tight, why not to think of fixation of the medial rectus to the medial orbital wall?
It has been described, but usually it requires an oculoplastic surgeon with me, because I have to create a periosteal flap, not just suturing of the sclera to the osteum. And it's quite difficult, and it's also not that good looking at the end after surgery. But it's always a last resort in some cases.
Maybe, yes. I never did that, but it's an option. Why not?
Any questions? Dr. Hala, Dr. Rahab, Dr. Ghada, any questions?
I just wanted to say that it was great what you did, doing the superior oblique also. And in any large exotropia, I'm sure, yes, I know that the superior oblique here was tight, but just to add that when you have a very large angle exotropia, doing both the superior and the inferior obliques, recessing them, Zaima Rasha suggested, will also help with the reducing the amount of exotropia. So, thank you.
Thank you, Dr. Hala. And thank you, Ahmed, and Dr. Hatem, Dr. Rahab, and Dr. Dina. And thank you very much, Dr. Lubna, for your very fruitful insight. And I think we can terminate this episode. And we're looking forward to seeing you our next episode, number 9. And thank you very much for attending. Thank you.
Thank you.
Thank you. Thank you.